Okay, good morning, everybody, and welcome to our sixth episode of our Game Changers series, where we'll be talking about COVID-19. Welcome back to so many of you who have joined us before. If you are new to this broadcast, I hope that you'll enjoy your time today. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of the UNC Health Foundation. And as I said, you're going to hear from a couple of people today, Dr. Cindy Gay and Dr. Jonathan Parr. But to get us started, I'd like to ask Dr. Wesley Burks to offer a few remarks. He's our CEO of UNC Health and Dean of the School of Medicine. And before I turn it over to him, I forgot to remind you, please feel free to chat with other participants in the chat function of your Zoom, and then also submit any questions that you might have through the question and answer option. You've submitted a whole bunch of questions to us in advance. We'll try to get to all of those too. But for now, Dr. Burks, I'll turn it over to you.
So thank you, Leslie. And I'm thankful for being with the rest of you this morning. It's nice to be back together. I'm also excited about being joined today by Dr. Cindy Gay and Dr. Jonathan Parr, two of the leading experts here at UNC School of Medicine and UNC Health that have worked in this space of COVID-19 for the last several months, and even way extending back beyond that. The benefits of their work to the people of North Carolina and really beyond internationally, we're really just grateful for them to be part of who we are and watch the amazing work that they're doing. Whether it's Cindy and the vaccine trials that she's doing and that she'll talk about, or Jonathan and the work he's doing both in the laboratory as well as heading some of the inpatient services, they do some amazing things. And like other people that have been on with us, for me personally, it's a privilege to work with people that do really, really outstanding work in taking care of people and making sure that we meet our mission of taking care of the people of North Carolina and beyond. A little bit for me personally as we transition, because you're really on to listen to them talk. What I want to talk about first is just some statistics since the last time we talked about COVID and its impact on our healthcare system. So last time we talked, we were at about 140 patients in the whole system across the state. Over the next couple of weeks after that, then it got down to about 115. And now literally in the last few days, we're back up to 160. So our high in the later spring was about 190. So it kind of puts it into perspective. What you've been reading online about the resurgence of some, that's what we're feeling all across the state in our healthcare system. We have over 2,700 cumulative across the system hospitalizations. What we've talked about before has been pretty consistent, average age in the mid-50s. Many of the newer patients that have come in have been for us east of Interstate 95. So in some of the rural hospitals that are part of our system. Our testing rate that was just barely over 8% positive rate is just under that now. It's not appreciably moved, but it's like 7.9 something, so about the same space. And now we have over 300 deaths that we've had in the system, less than that when we talked last a few weeks ago. So that's an update in the picture that we're seeing on a regular basis. So for each of the sessions that we've had previously, we've had just a time for each of the guests to have some personal reflection on what this has meant to them for the last 6 or 7 months, how it's changed their life, both personally or professionally. And so Cindy, if you don't mind starting just some personal reflections on what the last few months have been for you.
Yeah, I think, and good morning, everyone. Thanks so much for inviting me. It's a pleasure. I think if you had asked me 10 or 12 months ago if I was busy and doing, the most I could, I would have said yes. And then here we are, fast forward, and essentially all the clinical work and research that we were doing before is we've been able to reopen it. But now, as mentioned, I've helped to lead one COVID vaccine study that's enrolling now and gonna probably wind up in a week or two, and then was asked to have a co-chair role on another vaccine study that's coming up. So there is apparently a limit to the hours in a day, but apparently you can squeeze a few more things out of it if you're asked to. And as we all know, we feel the need and the urgency is there. I would say it's been allowed. When I was asked to be involved with the second study, I sat down with my husband, who's also a physician and a researcher, and my two kids, and I said, do we want me to do this? Because it's going to mean long hours and I'm going to be around a little bit less. And everybody said yes. I'm sure my husband regrets that over the last several months, and Jonathan's smiling, so I'm going to assume it's been a little bit the same in his house. But we, frequently, like everybody else, regroup together as a family and decide that the sacrifices and some time away is worth trying to help solve these problems and issues. So it's been a real challenge. Our group, meaning our ID physicians and research staff and pharmacists, everybody has been pulled to do other things. So in the process of trying to get up to large vaccine studies, while we have perhaps fewer people here in the office and other people pulled to do either clinical duties or other research, it takes a lot of collaboration. It takes a lot of hard work, but we're willing to do it. I was asked recently about how we are all like, what are the buzzwords, self-care or well-being? And I was honest and I said, well, I'm not really sure. I guess I should speak for myself. I'm not sure that I'm really doing anything that qualifies as self-care. However, I think if you polled most of us and asked us, would we rather be working long hours trying to address this really big problem, or would we rather be doing some self-care? I think the vast majority, yes, 100 out of 100 times would say we'd rather be helping address this problem.
So Cindy, thank you. So Jonathan, just thoughts on how it's affected you and your family in the last few months?
Sure, and thanks for having me. I echo Cindy's comments. This has been a really crazy time, and if I'm honest, I am very tired, but I'm also honored to be a part of the response to the pandemic, like Cindy. You've heard many people use the analogy of a marathon, but I think that's really fitting for what we're doing. Up front, all of us were sprinting, trying to figure out our destination, get a sense for the race, and that was really, really intense. And I have been trying my best to kind of shift into a different mindset where I'm in this for the long haul. And so it's been a tough stretch. I usually am focused on molecular epidemiology of infections, mainly in the Congo, certainly not studying coronaviruses. So life's pretty different at work, and obviously it's different at home for all the reasons that you and everybody on this call understand well. My kids are remote schooling. We have a different arrangement now than we've ever had before. But despite those things, it has been a real pleasure to be a part of this response, to work with colleagues like Cindy and also colleagues across the health system. There's been a real sense of unity despite it all.
So Jonathan, thank you. Do you want to go ahead and give an update on coronavirus and where things are through our system and the work that you've been leading?
Sure. I'd be happy to do that. So by way of introduction, I'm an assistant professor in the Division of Infectious Diseases. And as I mentioned, typically my work is focused on molecular epidemiology of several infections, mainly malaria in the Congo. So working on COVID has been new for me, like everybody else. My task is to give you an update on COVID-19 and also give you a little bit of a taste of what it's been like to care for hospitalized patients. I am a co-director of our division's inpatient services, which means that I've had the pleasure of leading a group of excellent infectious diseases physicians caring for people with COVID-19 who are sick enough to require hospitalization here at UNC Medical Center. So as you know, the COVID-19 pandemic is global and it's worsening. The graph at left shows the number of cases and deaths over time, and you can see that this graph is continuing to go up and up. The map at right shows the distribution of the over 37 million cases worldwide and over 1 million deaths. And as you can see, there's no part of the map that's spared. Every region and every country has been affected. Next slide. There have been differences in what the pandemic has looked like, depending on where you are. This has been in the news and it's obvious, but I think it's useful to look at some of these curves that show case counts over time. Obviously, everything started in Asia and then hit Europe, followed by North America. And you can see several humps in these curves, which occur for a variety of reasons, but suffice to say that cases are still very real across the globe and unfortunately are increasing in many locations. Next slide. The US has the unfortunate title of world leader in COVID-19 cases and deaths. This map at left shows the incidence of COVID-19 across the country, showing the number of cases per 100,000 people over the last week. You can see that the Midwest and Mountain West regions are especially hard hit right now. But if you focus in on the Southeast and across the country, you see that cases are still common everywhere, including in our state of North Carolina. The figure at right, I like because it helps put COVID-19 in context. This figure shows causes of death per week in the United States over the last several years. All of us are aware that heart disease and cancer are top killers and have been for a very long time. But COVID-19, you can see, just really surged and for a brief period of time was the #1 cause of death in the United States. There's been a lot of discussion about COVID-19 in comparison to influenza. And I like this graph because it really shows, I think, pretty clearly that these are very different infections. Certainly influenza is important and dangerous, and I would encourage all of you to get your flu shots. But COVID-19 is far more deadly. It's very different. It's been occurring throughout seasons. And I think comparisons between COVID-19 and influenza are unfair. Next slide. So the figure at left again shows case counts in the United States over time. You can see that there are two distinct humps. These I don't think of as waves. I actually think they simply correspond to the virus diffusing across the country. But the concerning thing to me is the far right of this graph in blue, where you can see the cases starting to tick up again countrywide. At right is a fairly busy figure. This is actually meant to display the United States, and each square shows case counts by state over time. As shown on the last slide, you can see that in the Mountain West and the Midwest, these squares that are red, these states have had pretty marked increases in cases. But if you look in our region in the Southeast, you can see that North Carolina, South Carolina, some of the states in the region had peaks that came down. And now if you can somehow see, I know it's kind of small, you can see that cases are again starting to pick back up. Next slide. So North Carolina is indeed starting to see a rise in cases, as Wesley mentioned in his introduction. These are case counts over time in North Carolina. We've had over 230,000 confirmed cases as of yesterday. And I just want to emphasize that these are confirmed cases, meaning PCR or a small number of antigen-based diagnoses. And so this is probably just the tip of the iceberg. Black and Latinx populations have been disproportionately affected. The figures in the bottom left show the breakdown of cases in our state. In addition to disproportionately impacting Black and Latinx communities, you can see that the majority of cases have in fact occurred in the 18 to 49-year-old age stratum. This is important because it kind of goes against some of the common wisdom that this is an infection that only affects or only hurts people who are elderly or have comorbidities. That's not true at all. It has affected people of all ages. Our test positivity rate across the state has been fairly stable at 6% in recent weeks. Over 3.5 million tests have been performed in North Carolina to date. And I will say that you guys, I believe, have heard from Melissa Miller in this very forum. And I just want to make a brief point that UNC has really been at the forefront of building very effective and efficient diagnostic testing capacity. And for me as a clinician, that has made taking care of hospitalized patients so much easier. Next slide. So some North Carolina counties have been harder hit than others. Earlier in the pandemic, this map was much less homogeneous, and we were very clearly seeing clusters of cases coming from specific counties among our hospitalized patients. And while cases are widespread, you can see that in Mecklenburg and Wake counties especially, there are a large number of cases right now. Next slide. Here at UNC, one positive or negative thing has been that our numbers of cases have been fairly constant for the last several months. This is good because we've been able to work very hard to build and implement systems to take care of these patients and to do the best that we can for them. But it's also been exhausting because we haven't had a period where cases went away and where we could sit back, take a deep breath and regroup. The cases have been steady throughout. So the top left figure shows hospitalizations across the state, and the figure at the bottom is data just from UNC Medical Center. Wesley already mentioned some of the numbers, but we've been seeing steadily between 20 and 30 patients at any given time in the hospital. So as I mentioned before, I have the pleasure of co-directing infectious diseases inpatient services. I've shown a picture here of the entryway to one of our isolation units on the 6th floor of Memorial Hospital here in Chapel Hill. And I've included it because I'd like to give a nice example of how we've been able to work together to deliver high quality care to patients sick with COVID-19 in our hospital. So early in the pandemic, it was clear that this was a very infectious pathogen that was spreading very quickly, and also that there were risks not only to patients in the hospital, but also to healthcare workers. So it was a really amazing thing to work closely with infection prevention experts at UNC, our nursing colleagues, hospitalists, critical care medicine, infectious diseases doctors, to come together and scheme up a way to build these isolation units in our very own hospital, learning lessons from Ebola units in Africa. I think you may have heard from Billy Fisher or maybe David Wall. They were a big part of this. And anyway, the point I want to make about these units is that for me as a provider, it's been a really amazing thing to be a part of. Indeed, we do wear respirators and we take a lot of precautions. But it's enabled us to provide really high quality care and do it with some peace of mind. To my knowledge, we have not had transmission events on these units, either from staff like me to other patients or from patients to staff. And when you're a provider in the trenches, feeling a little bit tired from running the marathon, it's nice to have some peace of mind that you can come home at the end of the day and know that you've done your best to keep your family safe. Next slide. I also want to say that care of hospitalized patients has improved over time. When we were first in the midst of this, as Cindy can say very clearly, we really had no idea what to do. We were flying by the seat of our pants. We knew a little bit about this infection. We had very limited therapeutics available. And actually with Cindy's leadership, every week we convened a group to review the available evidence and figure out what treatments to offer to our patients and how. Since then, there have been an unbelievable number of publications, over 60,000 publications on PubMed as of last week in a short period of time. And so we've been able to continue working together and now have been able to build some streamlined algorithms for care at UNC Medical Center. I need to give credit to Brian Bramson, a physician in our group, who has really pushed forward the development of this algorithm. But it has not only helped us implement evidence-based care to our patients, but it's also allowed us to standardize care at UNC Medical Center across our services. And I think there may be some opportunities to push this out across the health system in the near term. Next slide. So in conclusion, COVID-19 cases are increasing worldwide. The US has more cases than any country in the world. North Carolina has seen fairly steady cases in the recent past, but as mentioned, our numbers have really started to increase in recent days. Unfortunately, COVID-19 has disproportionately impacted Latinx and Black communities in our state. But on a positive note, hospital care has improved and continues to improve as new therapies become available. Last slide. And I'll just say in conclusion that while this has been an exhausting process for me, it truly has been a pleasure to work together, not only with colleagues in the health system and in the medical center, but also across campus. You've heard in this forum, and you will hear shortly from Cindy and from others, that there really is amazing research being conducted at UNC at all levels. There's innovation in the hospital, some of which I discussed with you, but really cutting edge bench research. And there is an unbelievable amount of crosstalk and collaboration. And I can't highlight that work enough, but for those of you who support Carolina, I think you should feel very proud about the collaborative research and work that's being done on campus. So I'll stop there.
Okay, Jonathan, thank you. That was a great overview of the work that you and your colleagues and so many people across the healthcare system and across the campus have done. There were a few questions as you were talking. I'll go ahead and try to get to those. One of them is, how much exposure do you need in order to get the disease? So help people understand what the latest thinking is about exposure and mask and indoors and outdoors and all the things related to it.
Sure. Surprisingly, we're still learning a lot about this, and the answers are not clear. What we do know is that people who are exposed to family members or friends or other contacts who are sick with COVID-19 are at risk for infection themselves. This is especially true for household members, but can also be true for people interacting with others, especially in the indoor environment. So some of these numbers are just coming out in the literature now, but there are other numbers that will come out from UNC in the near term. We know that within households, attack rates, or meaning the risk of infection of a household member, is probably somewhere around 30%, perhaps even higher, and some of these numbers haven't been published yet. So the risk is very real. It's possible that the stage of infection, or it's known that the stage of infection influences infectiousness. If you're around someone who's very early in their infection, when they have really high viral shedding, your risk is probably higher. But I just want to conclude this answer by saying that there are things that you can do that really will reduce your risk. Many of these have been discussed in many different arenas, but mask usage is actually very effective. Physical distancing is very effective. This is not just anecdote. This is well known. It's studied. There are nice studies that I could highlight that show that. And I do think while this infectious virus puts all of us at risk when we're around other people, there are things that we can do to minimize our risk and also enable us to have human interaction, which is not only required for productivity at work, but also survival throughout this pandemic.
Okay. Another question that came up is that, and this is a little bit difficult to try to tease through, but I know you've thought about it and y'all talked about it, is what about the US in particular is causing us to have the statistics that we do? What are we doing that others aren't, or vice versa? And how difficult is it to tell that because of the differences in cultures that we live in?
Yeah, so this is an important question, and one that a lot of people are talking about in different ways. And in my own opinion, I feel that the US's response has been inadequate in many ways. Specifically, there's been a lack of coordination at a very central level, which has made it difficult for people on the ground, either at the local level or even at the state level, to have the resources they need or the buy-in they need to implement effective public health measures. There was a pretty scathing editorial published in the New England Journal by all the editors of the journal this week, exploring some of the reasons for the United States' unfortunate position in the world as world leader for cases and deaths. And independent of politics or economic views or the like, there is no question that this virus has burned through our communities in a way that it hasn't everywhere else. And some of those reasons, I think, outside of the medical realm, are just intrinsic to how we operate in the United States. And I would never sacrifice my liberty. This is what makes our country great. But the underside of that is our own free choice makes it a little bit easier for us to relax our physical distancing, mask usage, and has probably led to some societal decisions that have resulted in blown opportunities to get this under control.
Okay, and it's a complicated question and answer, so thank you. Another question that people commonly ask, the flu season is coming. We have some information from other South America, other places that where flu has come through. What do you anticipate will happen here in North Carolina?
It's hard to say. I do think we're going to see increasing flu cases. We're already seeing flu cases now in our health center. But it's possible that the flu season could be attenuated or less severe simply because the measures we're taking to prevent COVID could dampen down the case counts. On the flip side, it's going to make things a little bit more difficult because people who develop fever, sore muscles, or symptoms of flu, we as clinicians are going to have to think very hard about whether they have COVID or influenza. And there are several working groups here at UNC who are working very hard to design efficient and effective testing algorithms for our patients who come into clinic with symptoms that could be flu or COVID. But I guess the answer to the question is no one knows. We will see. I'm sure hoping this will be a better year than most. And I'm optimistic that our mask usage, hand washing, and physical distancing will help, but we'll see.
Okay, good. So one last question is that there's been a lot in the news recently about testing because of the president's illness. And there are different types of tests, the rapid test, the PCR test, that can be confusing to all of us as we read things online and publications. So walk through that again, how you use testing in different populations, those that are symptomatic, not symptomatic, for screening. What's the right use of the test that we have available?
Sure. This is a great question, and the answer is really rapidly evolving. So at UNC, as I mentioned before, we've had the benefit of really robust PCR testing capacity due to the clinical micro labs, really amazing forethought. So we are using entirely PCR-based testing in our clinical decision-making, which is really great because it's a very sensitive test, a very specific test. But on the flip side, it's expensive, and as you've seen in the news, it's been difficult to scale up PCR-based testing across the country. So antigen-based tests have the advantage of being really well suited to rapid diagnostic formats, which has many advantages which are obvious, right? If you become ill and you could simply use a rapid test and get an answer, then you could change your behavior, or you could talk to your family members, or you could talk to your colleagues and intervene. So as it stands now, there are a huge number of tests in the pipeline and a huge number of tests that are out. The antigen-based tests to date have had inferior performance characteristics compared to PCR, meaning they're less sensitive, they're less specific. It's more likely that you could get a false negative or a false positive. But we are struggling on the clinical side with people who have very, very prolonged PCR positive courses. This is almost the norm. People are positive for a month or 2 months, not infectious, but still positive. So that may be more information than you want, but I think there is progress being made at a policy level now to harmonize antigen-based and PCR-based testing approaches, where ideally you find a sweet spot where maybe you use a rapid test that has a little less sensitivity or specificity, but can be done rapidly and identify people who are infectious, and then you support that with PCR-based testing in the right patient population. So very much a question that's still in flux, very important. And I hope in a month, we'll be in a much better position in doing even more rapid testing, because in order to address the problem, you have to know where the problem exists, and better testing capacity is critical to that.
Right. So Jonathan, thank you. That was a great overview, and I appreciate you answering some really difficult questions. So we'll turn now to Cindy, and she's going to give us an update on some of the work she's doing in the vaccine trials.
Great, thanks so much. That was great, Jonathan. I hope my questions are easier than yours. So I'm going to give an overview of some of the COVID-19 vaccine studies that are ongoing at UNC. On this slide, these are not the only COVID-19 vaccine studies that are in process. These are the ones that are sort of most advanced and being conducted in support by the various groups at the top. So that includes Operation Warp Speed, BARDA, NIH, and CoVPN. The CoVPN is a new network that is really a combination of investigators and sites and many other research support staff that previously focused on HIV vaccine trials and HIV prevention trials. So it's a group of very experienced research sites that have been working together. So as you see it listed, these are the studies that are either open or soon to be supported by these groups. The two in blue are two that UNC is a confirmed site for these studies. And I just thought I would list up there that all of these studies, the sponsor are the companies that are making the vaccines. They do have some various technology, which is in the second column, and just listed sort of more as for your information. As part of this support from the various groups, each of these companies is or has committed to providing a certain large number of vaccine doses if the vaccines are found to be safe and effective. And on the right, you can see sort of the targeted enrollment opening. So the Moderna study, which UNC is a site for, and I'll talk about a little bit more, opened initially on July 27th. We opened a little bit later at UNC and is ongoing. And there we have we project 1 to 2 more weeks of enrolling on that study. As you may have heard, the second one, AstraZeneca, this study is on pause to allow review of a safety event. And just this morning, we also heard the next study, Janssen, is also on pause for another safety event. And I can talk a little bit more about that if that's helpful. Also in blue is a study with the Novovax vaccine. UNC is a confirmed site for that, and the study is anticipated to open to enrollment in mid-November. I am also a co-chair for that study, which has a little less impressive given the various groups and a number of people who are supporting the study. But nevertheless, maybe helpful to sort of round out how these studies are happening and et cetera. UNC has been asked to be a site for the Sanofi study, but as you can imagine, the timelines for when the studies open and overlap are a little hard to predict. So it's not clear whether we will be a site for that one yet. Next slide. So I don't want to get too nerdy, but I do think it's helpful to try to explain with a visual what these vaccines are trying to do. Although the vaccines that I just showed on the prior slide all have slightly different technology that they're using, the one thing they have in common is that they're all targeting one specific protein on the coronavirus. None of the vaccines can actually cause infection. They are only trying to target an immune response to this one protein which sits on the outside of the coronavirus. So on the figure on the left, the sort of large purple circular thing is a coronavirus. And as you can see, projecting from that and sort of multicolored, almost a triangle, is something called the coronavirus spike protein. This coronavirus uses the spike protein to bind to our human cells. So on the right and sort of blurred is a big human cell. And you can see sort of a circular studded thing on the outside of our cells. So the coronavirus spike protein has to bind to that ACE receptor, that little blob on our cells. And it's that binding that allows some physical changes and allows the coronavirus to get inside to our cells. All viruses must rely on essentially the machinery in our own human cells to make more virus. So it's a critical step for the coronavirus to bind using the spike protein to our own cells in order to get inside and be able to make more virus and thus cause infection. Next slide. The goal of all these vaccines are, again, to target immune response just to that spike protein. So the idea is that we introduce that protein through the various sort of platforms of technology, and then our immune system recognizes that protein as something foreign, produces antibodies that are specific and bind to that spike protein. So the idea would be that through a vaccine, you get an immune response to that spike protein, you make antibodies, and those would persist for some amount of time. And then if someone is exposed to the coronavirus, you have these antibodies floating around that can then bind to the spike protein. And as you can tell in the figure, essentially prevent it from being able to bind to our human cells and allow the coronavirus to get into our cells and set up infection. So in the early phase studies of all of those vaccines that I showed on the earlier slide, we have both an animal studies, phase 1 and phase 2 studies, that all these vaccines do in fact create an immune response, production of antibodies that are specific to that spike protein. However, what we don't know is whether there will be sufficient number of antibodies and whether they will be effective enough to prevent or allow enough binding to the spike protein to prevent infection. This is what we're hoping to answer with all these studies. So hopefully that sort of clears up a visual of how these vaccines work. Again, the goal is to have the production of antibodies that target that spike protein, only one small piece of the protein, and hopefully we'll see it's going to work. Next slide. So as I mentioned, UNC is a site for the Moderna COVID-19 vaccines called the COVE study. All of these studies are phase 3 studies, so sort of the final stages of showing a safety and efficacy. They're all randomized, placebo-controlled, and blinded studies. For the Moderna COVID vaccine study, really there are two main questions that we want to answer. One is whether it's safe. It involves 2 injections of the vaccine or the placebo about a month apart. And then we also want to see if the vaccine will be effective in preventing symptomatic COVID-19 illness. So not just people infected, but preventing people having symptoms related to COVID-19 or illness. They're also going to look at some other objectives, which is, does it prevent infection altogether? Does it prevent severe COVID-19 illness? And does it prevent death as well? The target enrollment for the Moderna study is 30,000 participants. At one point or another, there were over 100 US sites that were enrolling on the study. As I mentioned, UNC opened a little bit later than the overall study. You can imagine the logistics of getting over 100 sites up and rolling. It is somewhat daunting. So we opened on August 27th. And I don't have the numbers from just this week, but as of last week, we had enrolled over 150 participants onto the study. In the last several weeks, the enrollment has narrowed a little bit to just enrolling minority populations, and I'll talk a little bit more about that. But I think I'm just tremendously proud of our research team for being able to enroll that number of participants in a relatively short amount of time. As many of you may have heard in the media, but also quite early on at UNC, we felt a real commitment to allowing and facilitating enrollment on the study across the diverse groups that have been really impacted by COVID-19. So in North Carolina, as Jonathan mentioned, and across the United States, that includes the Latino community, African American, and those over the age of 65. And I'm, again, really proud of our team because we have enrolled about, I think it's even better, 25% Latinos on the study, 25% Black or African American, and about 20% now over the age of 65. The American Indian population has also been particularly hard hit. We have not seen an incredible enrollment on our study with that, but we do continue to prioritize it. Next slide. So as I mentioned, UNC has been selected as a site for another COVID-19 vaccine with the Novovax Vaccine. This is also, again, a phase 3 randomized placebo-controlled blinded study. This vaccine is a more typical sort of protein-based with a booster or adjuvanted. Again, the primary objective is really to see if the vaccine versus placebo can prevent symptomatic COVID-19 illness. It's also a 2-dose vaccine series given about 3 to 4 weeks apart, so very similar. The target enrollment for most of the studies is the same. So for this one as well, we're looking to enroll 30,000 participants. And this will be mostly in the United States, but they are going to have some sites in Mexico as well, given the epidemiology there. The enrollment for all these studies is competitive, given the sort of urgency to try to get an answer about whether the vaccines are safe and effective. So we would have a target enrollment of about 350, but we'll essentially do the best we can with the amount of time we have. We're going to do something slightly with the Novovax vaccine study that we just weren't able to get off the ground with Moderna. We're going to have 2 sites. So instead of just enrolling participants at sort of the UNC Clinical Research Center, which is right next to the hospital, we're going to have an off-site campus, which we think will be a lot more convenient and help facilitate additional enrollment of folks. So we'll be a clinic space where people can literally park outside and just walk in. We think this will be very helpful with the elderly population, which we are hoping to really facilitate this opportunity to them if they're interested. In addition, and maybe of interest to many on the call, is that we're also partnering with UNC Chatham Hospital. This was something we started to try to work on with the Moderna study, but again, time just didn't allow. And I'll talk a little bit more about why that's particularly of interest to partner with UNC Chatham. Next slide. So for all of the studies, but in particular the Moderna and the Novovax, the study population that we're really looking to enroll are those who are at some increased risk for COVID-19 infection. There are kind of really 2 big reasons to do that. One is that if we feel, and we do, that we might have an effective vaccine that would prevent either illness altogether or prevent severe illness, you would want those who are at the most increased risk to potentially benefit from the vaccine. The other is that since we're trying to prove that it's effective, we need to have enough events. We need to have enough people in the placebo and the vaccine arm, those who receive one or the other, get COVID-19 infection so that we could show a difference, that we could show a difference in either the severity of illness, that we could show a difference in illnesses altogether. And then, as I mentioned a little bit earlier, we also want to see whether there's an impact on severe illness, on death, et cetera. So we need to have people who, through no fault of their own, are at some risk for acquiring COVID-19 infection due to the occupations that they have, or that they live in elder care facilities, for example. And then, as we know, certain communities have been harder hit than others, and we also want to make vaccine participation and the potential benefit available to those groups. Aside from those who have to be at increased risk, we also want to prioritize enrolling individuals who are at increased risk for severe disease. So for these studies, that includes folks with diabetes, cardiac disease, chronic lung disease, liver disease, and obesity with a BMI over 30 or 40. Next slide. So Jonathan really kind of talked about this earlier, and this, I'm afraid this slide's a little bit outdated, but I did want to take a minute to sort of explain why we were very committed to enrolling or making study participation available to the different minority groups that have been impacted. And again, it really comes down to, if you feel like you have something that's effective or potentially effective, I think we have a moral and ethical obligation to let people in those groups know about the study and decide whether they want to participate. And as the slide indicates, although Black and Latino populations make up a smaller overall proportion in North Carolina and elsewhere, they are having an increased number of cases, and as per the figure per 10,000 people. Next slide. So as I sort of addressed earlier in my opening comments, it is a challenge to, one, get a large study trying to enroll this number of participants off the ground in sort of COVID times, which does create some restrictions that we normally don't have to deal with. And so how do you do that? So I would very much echo Jonathan's comments about how it's been really uplifting and remarkable how collaborative people at UNC have been. So for example, one of the things that we've looked at, and one of the reasons to partner with UNC Chatham Hospital and to go to Chatham, there is a very large number of the population that is comprised of Latinos in Siler City, which is situated in Chatham, and also African Americans. And it so happens that Steve Kaiser, who's one of the geriatricians here at UNC, has a very key role in helping to support a clinic there in Siler City that's providing free healthcare to predominantly the Latino population. And as indicated on the sort of photograph in the right upper corner, there are even some of the dental students that go to the clinic and provide free dental care with some regularity. One of the obstetricians from UNC also goes to the clinic with some regularity to provide some care. So it's a place where the clinic and Steve Kaiser and group have really built up trust within that community. And so it seemed a really smart idea to partner with Steve and the clinic to try to get the word out about the vaccine studies and even see if they could help sort of recruit to the study. Steve and his group have been really remarkable and sort of helping us figure out the logistics of how we would do that. One of the things that may help with those logistics, and in COVID times, you think about things you would never have thought of before, is how do we take a study to the community versus asking them to drive 45 minutes from Siler City to us? Well, the way you do it is through a crazy matrix sea blue RV van there in the bottom of the picture. So as part of these vaccine studies, there's a group that provides these units that are equipped with clinic rooms on the inside and come with some additional nursing staff and even a driver. And so it allows you to sort of take a clinic space to a community and be able, we're hoping, and about 99% sure we're going to pull it off, to be able to drive it to Siler City and be able to recruit and do some of the study visits there. I think this is really key for a couple of reasons. One, it's not always easy or even possible for people to drive to UNC Chapel Hill to enroll in a study, even if they're interested. A lot of the folks who we feel are at risk for COVID to begin with are folks who have an essential worker job. They have to show up, and for a lot of them, they don't get paid if they don't come to work. So if we can also provide, again, taking the study to them, provide a way for them to spend less time away from work, or even just make it feasible at all, this is something that we're willing to try to make happen. So there's a lot that goes into it, but we feel the lift is worth it. And hopefully I'll have more to come on how that all goes. Can you go back to the slide? I want to talk a little bit more on the previous slide. Yeah. So the other partnerships that we've done, we've worked with some folks in the geriatric division at UNC. Jen Busby-Whitehead has been incredibly supportive, and we went to a lot of the community retirement centers to make those centers and the residents there aware of the COVID vaccine studies. And we're going to continue to work with them for Novovax to try to see how we can facilitate that for a lot of these individuals living in elder care facilities who we know are at risk for infection, but also we know are especially at risk for severe infection and deaths. So we're hoping to partner with them to make that easier for them. In addition, the last three groups on the slide, the endocrine research group, the nephrology group, and the family medicine folks at UNC have all reached out to us to see how they could help make their clinic patients aware and recruit to the study. They've done this without asking really for personnel support or anything else. And so I can't really say how wonderful that is, because everybody's having to work harder. Everybody's having to do a little bit extra work just to make the usual things happen that we do, but they're taking their own time to really sort of provide this opportunity to the clinic patients. But I also think just because they understand how urgent and vital an effective vaccine would be for all of us. Next slide. So what else do you do when you have to enroll several hundred participants onto a study and have not a lot of time? I would say I just sort of wanted to show this because, again, it's just uplifting to me when I'm having really long days. So I called it Big Ask of Great People. So getting to this issue of wanting to enroll diverse communities that have been hard hit, that message hasn't perhaps always been delivered in the best way. I've learned a lot. I think you also have to be sensitive about when you're sort of, I'll use the word targeting, but how you're approaching groups in order to enroll in a study. And it needs to be done in an informative way so that they understand about the potential benefit, that we understand we haven't done a great job with this in the past. And now is maybe a time to start addressing that. So as part of that, we felt like we needed to show some people who know a lot and are in sort of leadership positions, rolling up their arms and being willing to enroll on the study. So in the upper right-hand corner is Ernest Grant, who used to work in the burn unit at UNC, and he's now the president of the American Nurses Association. There's a whole little blurb where he talks about why he felt this was important. And the bottom left is Ralph Barrick, who enrolled on the Moderna study and was also just so gracious to explain a little bit about how great vaccines historically have been and why he's also willing to do it. In the middle is Michael Herte, who's one of our ID clinicians who wonderfully speaks Spanish fluently. And so we created a video addressing some of the concerns and how vaccines work, such that it would be available to Spanish-speaking individuals. And then on the bottom right is Dr. Craig Cameron, who's sort of the head of microbiology at UNC, who also just, graciously said, yeah, I'll do this, and explain why, as a prominent Black man, what's the importance of bringing participation in studies and having people of color participate in the studies. What's the meaning in that to him, and why it might be of interest to others. I provided the link at the bottom if people want to actually see the videos and hear what these folks have to say, because they're way more eloquent than I am. But I think it just speaks a lot to, again, how everybody understands the importance and are really willing to do their part in general, but also to support these vaccine studies. It's been really tremendous. Next slide. So I can't help myself from sort of putting a blurb on how people might go about showing some interest in the studies. There is a CoVPN registry, which is not study specific, and it's not even specific just to vaccine studies, but is a way for people just to express an interest. It's not a commitment. It's just to show, yes, I might like to be contacted about being in a COVID-19 vaccine study. I did it myself to see what it was like, because I figured if I'm going to ask other people, I should do it. It takes about 8 minutes to answer some questions about what your risk would be. And if people are interested, they can enter a UNC site code that would direct their information to us a little bit more efficiently. Next slide. And this is, I was just going to end on this. This is sort of one of the sort of flyers that's been developed to help sort of get some interest and explain the studies to folks. So I just wanted to sort of end with that, because it's, I think, really nice. And again, directs people mostly to the registry. I think I'll stop there.
Okay, Cindy, thank you. It's really good information. I know people ask a lot of questions while you were talking, and we could spend literally another hour talking about the vaccine issues, both specific for the vaccines as well as the societal issues. One question I do think that it would be helpful to talk about is the Johnson & Johnson issue that came out today. You alluded to it, that we would come back to it. The Data Safety Monitoring Board put a hold on it. That's not an uncommon occurrence for any trial that people are doing. We just happen to read about it a lot now because of the pandemic and what's going on. Help people understand the role of the DSMB, what happened today, and how uncommon it is or isn't.
Yeah, so I do think it's important for people who, not like ourselves, sort of live and breathe research. When you're developing a study, you build in safety measures that would allow, at sort of any one point in time, sort of frequent checks about whether everything's going the way that it should. So there's ongoing safety evaluations, and in the study would be built that if there was what I'll use the word sort of a concerning, or I'll say a severe safety event, or just an event in a participant. And if it's not clear whether it's related to what was happening on the study or not, there would be an automatic pause such that no one else would be enrolled onto the study or receive additional vaccine, such that people who are independent from the study. So before the study opens, people would convene a group of who are not directly involved with the study, have no conflict of interest with the study, but are willing to essentially be on hand if such an event should happen. And also at designated points to look over the safety data and make sure everything looks the way that it should look, and there are no concerns or questions to have. And you're right, these are common things that have to be built into the studies so that we can always be monitoring and checking the safety of a study and whether it's safe for the study to proceed. I think what's happening, and I can say myself on other studies not related to COVID-19, we've had this happen before, that there's an event. It meets some criteria for when we feel like we need to pause and look at it. We send all the data to some independent folks to look at, so a DSMB or as one of the groups, and ask them to look at the information, ask and get additional information if they need it to be able to make a decision about Do they think the event is related to, in this case would be the vaccine or not? Do they feel like it's a health event that happened but wasn't related, just sort of, not bad timing, but coincident timing with when they were participating in a study? So I would say, I don't know if common's the right word, but I would say not uncommon. I think the thing to keep in mind is with these studies, which is slightly different, for these COVID-19 vaccines, because we're so concerned about the groups that are at high risk for severe disease, so those folks who have comorbidities, oftentimes those individuals are excluded from early phase studies and in approval because they don't want some of these health events clouding the decision about whether it's related to the vaccine or the drug or et cetera. So oftentimes those folks will be excluded from participating in a study at this phase. So we are allowing folks with some of these comorbidities who will have health events. We expect that. So a lot of us would say this is an example of the safety measures and precautions that we build into studies working in the way that they need to, and that when there's an event, it gets recognized quickly. There's a response to it promptly, and that there would be an independent group that's going to look at the information and decide whether it's potentially related to the vaccine or not, and whether the study should continue.
Okay, Cindy, thank you. It's a good answer to a really complicated question. Certainly the public response to the vaccine and whether they would take it or not is complicated by the culture and the times that we're in. And then the rapid dissemination of this information that we might not get when it's a normal flu vaccine, and that takes a lot longer to happen. So all that just creates some anxiety about people, whether they would want to get it or not. And I'm still hopeful that with the rigorous approval process that's in place in the US, that when a vaccine is available and it passes through that we'll be able to get it to the people that need it most.
Yeah, I think one of the things I would add that I think does get missed with these studies is, although they're, and I get the concern about the studies happening at sort of a more rapid pace. I think, and I could speak to what's being sped up and what isn't. But one of the things that is perhaps of some reassurance to me is that there are more groups and experienced folks involved with these studies. So there's a plus and or upside and a downside to having more cooks in the kitchen with a large study like this. But one thing it does do that wouldn't happen with a typical phase 3 vaccine study is that you do have very experienced, very respected people at the NIH and within the co-VPN networks who also have to be involved at every stage of these studies. That makes a lot of hours and a lot of work on our side, but I would say, I think or would hope that it would provide some reassurance to other people that it's not just the sponsor that's making the vaccine and the FDA. There's all these other people who are going to be involved with thinking about and assessing these events, and just, the vaccine studies in general outside of these events. There's a lot more oversight and safety review in that.
Yeah, which is really good now. So anyway, thank you, Cindy, and thank you, Jonathan. You did an amazing job to describe what you're doing. And then what I feel, even standing at my computer, is the passion and the energy that each of you have for what you're doing, which is truly amazing. So I'll turn it back over to Leslie as she closes.
Okay, absolutely. Thanks, Dr. Birx. And again, thank you, Dr. Gay and Dr. Parr. As we come to the top of the hour here in the close of our program, I just want to thank you so much for being a part of today. We are going to take a little bit of a pause on our Game Changers series, and we'll look to start back probably after the first or second week in November. So definitely stay tuned for the next invitations to our Game Changers series. If you are interested in learning more about our response to the coronavirus, you can go to the UNC Health link here. And if you are moved by what you heard today and you want to support the work that we're doing in COVID-19, I would encourage you to check out our COVID-19 response fund at the link listed here, which we will also send out in our follow-up email to you. So again, thank you so much for being with us, and have a great day. Bye-bye.